Welcome to the Doctor's Corner with Dr. Kline and Janelle Elgaway.
Good evening and welcome to the Doctor's Corner on Caw 360 Network. I'm your host, Janelle Elgaway, and we are here with Dr. Kline. Welcome, Dr. Kline.
Hello.
Hello. Tonight we are focusing on the topic of how to talk to your doctor. We will also answer a few questions from our mailbag. The mailbag is questions that we are asked in previous shows on YouTube chat that went unanswered or questions that people have written in with. If you have future mailbag questions that you would like Dr. Kline to answer, please send them to my assistant, Jess Stewart. Her email is jstewart@caw360.com. If anyone would like to call in with a question this evening, you can do so at 415-915-2291. There are also two ways to listen in to tonight's program: through our website, which is www.cawnation, which is callnation.com, or YouTube channel, and you could put in the search The Doctor's Corner. So, Dr. Kline, is there any newsworthy information or stuff going on that has occurred in the last week that you'd like to share with us?
Everybody's been talking about the Medicare hard audits, soft audits. Basically, they're illegal audits that are going to start in January. And so already we're starting to see some takebacks. You see, they can't really do this in good conscience. They're going to try to do it. They're basing it on the CDC guidelines, which are illegal. They are voluntary and non-binding. And that wouldn't be so bad, but we have an agency that is binding and is legal, and it's the FDA. The FDA does not put any limits on prescription opiates. They're going to try to use a 90-quote audit, a 200-quote audit. You know what? People really love numbers.
Mm-hmm. Why do they?
200. You know, they just pick it out of the air. Right. Anyway, the take back is that if you've been on the medicine 2 months prior to the regulations, you're exempt. And when I read it right away, you could see that they're going to exempt palliative care. So, you know, we got to get back and work on palliative care and getting a definition. But so what do you have in the mailbag?
Yeah. Okay. So a question about palliative care. This person asked, I educated my physician about palliative care based off of Dr. Kline's advice and definition, which would make myself as a patient exempt from the CDC guidelines. But he will not diagnose me as such. Based on the definition of palliative care, not being only for end of life, can the physician be sued for malpractice? And second part is, can the CDC or FDA be sued and a class action lawsuit being the result?
Probably not. You cannot really sue the government. People talk about suing the government. It's a waste of time. You can focus your energies on other things. Lawsuits don't get you anywhere. They really don't. Even when they have big class action lawsuits, they're always narrow and they don't really get you anywhere. So what people need to do is turn to other types of advocacy. And so the big one, of course, is advocating with the general public. Okay, you got to get the general public on board. And then when the general public's on board, then you can go to your legislators. Mm-hmm. So if you just wander into a legislator's office and start yelling and screaming about chronic pain or painful diseases, they're not going to listen. They don't have a frame of reference. It'd be like if I went into a legislator's office and say, do you realize how much white clay is out there? You know, they don't have a frame of reference. But later, if I explain that white clay is causing to clog up rivers, and, you know, then with a little information, they go, aha. And still, then they're not going to listen to one person. So we've been talking about having roundtables with moderators and then inviting maybe some legislative aides, you know, to get this going. But really, lawsuits are a waste of time. And we live here in North Carolina, so I'm going to try, and maybe we can get people to try, to get North Carolina to come up with a definition for palliative care. It's real simple. You have a disease you cannot treat that has symptoms that, if relieved, would improve the quality of your life. That's it. None of the definitions that are in my article on Medium, and if you want to go there, you just Google Medium Palliative Care Kline, and you'll get right to the article. Or you can go to, I have a little web page, it's not a website, web page, thomasklinemd.com. Anyway, you can get the palliative care article, which I have assigned to a couple of editors. They're going to split it up. I had two parts. One is the palliative care, and one is how to make money on long-term patients, and I'm going to separate those two. But there's 5 definitions that I put in the palliative care article. None of them have any limitation on lifespan. And doctors will not accept new ideas right off the bat. So if you're in there with a new idea, and we're going to talk about this in a few minutes. So do you have another question, Janelle?
Yes, and several people were asking this. Does smoking really mean you have the addiction gene? And could you clarify, as it was not the same as someone who sells all their belongings for their fix or even picks through ashtrays. So does this mean I need to worry about becoming addicted to alcohol, for example?
No, they don't cross over. Nicotine is all by itself. The definition of a type 2 addiction, this is, the hardcore addiction, is you have a withdrawal syndrome when you stop. So that includes nicotine, some forms of alcoholism, and of course, opiates, heroin et al. So all of those have withdrawal symptoms. None of the others in type 1, cocaine, amphetamines, weed, and and some forms of alcoholism, there's no withdrawal. But we're creating a type 3 addiction, which we're going to try to define as a special type of alcoholism. And this is a person who needs constant levels of alcohol. Wakes up in the morning, gets up in the middle of the night, needs constant levels. May not be to the point of drunkenness, may just need levels. And we'll go through the DTs, which is a withdrawal, a dangerous withdrawal, by the way. Those are the receptor addictions. So no, if you have smoking, but if you've ever tried to quit smoking, it's pretty bad. It's hard. Mm-hmm. And it's like a mini withdrawal from opiates. It's a mini, but still you kind of go through the same stages. So.
Okay. Another question, what should we do if our pain clinic is forcing us to go on Bupe or Suboxone?
I think you need to, one, realize that Suboxone is a great painkiller. So you got to choose your battles. In other words, if it gives you pain relief, it's fine. What their motivation is, who knows? But given the climate that we're in, I would say go for it. Mm-hmm. Because, drugs that, this is just kind of my current thinking, but drugs that have the worst withdrawals probably are the most effective because they're binding more tightly to the receptors, kind of like if you're filling up the basketball with a little needle. If it's nice and tight and you're not leaking air, it's a better system. So I am not opposed to people going on buprenorphine or Suboxone because from my standpoint, I think it's a very good pain medicine.
Now, let me ask you, though, are people going to have problems if they don't go to that doctor any longer and go to the next doctor? And will they be thought of as a drug addict or a drug seeker?
Yeah, that's a good point. And, what I would do is say, doctor, I'm concerned about being labeled an addict because I'm taking this. So would you provide me with a letter of introduction that I can take to my next doctor? And I'll help you with it, doctor. I'll draft it if you don't mind. And you can help the physician, who's swamped for time, and say, here's what I would like it to say, and just send it to them in Word, let them put it on their stationery. They can edit it if they don't like it. But yes, And because of the difficulty with withdrawals, I think you should say, that I understand that this has a more severe withdrawal. So I'm asking you to provide me with this letter of introduction so everybody knows that this is for pain. Everybody knows I'm not an addict. And so that people will be more likely to continue this medicine should you, leave and get another job or be run over by a cement truck or whatever. That I'll have this. Yeah. And if they don't, then say, well, doctor, let me just think about this. I'll get back to you. See, then you don't close any doors, but you worry them that you're not going to be a cash customer anymore. And then you can still call later and say, I need another appointment. I've decided to go with it. Or you can come back and say, here, I've got some other ideas here. And we'll talk about how to get these ideas across in a few minutes. So any other questions from the mailbag?
Yes, we have as many as you would like to go with. But a lot of people have asked too, why won't the FDA speak up against the CDC?
Agencies never speak up against another agency. It's just the rule of government.
Do doctors still protect one another? Because it seems like doctors would always do the same.
No, they don't. Doctors are insular from the word island. Mm-hmm. Doctors don't protect one another. When a doctor gets arrested down the street, they all go, yeah, he's probably guilty. Instead of getting together, like labor unions, like let's stick together, the brotherhood and all that kind of stuff. No, doctors are not like that. And that's a serious failing. Mm-hmm. So. All right. Well, those are good questions. And shall we gallop into the evening's topic?
Sure. So our topic again is on how to talk to your doctor. Why is this such an important topic, especially with current situations between pain management doctors and palliative care patients?
The problem is that doctors and patients are speaking two different languages. The physicians are speaking the language that they're taught in trade school, which is medical school. Most trade schools teach people how to behave. Your plumber, when he comes to your house, isn't rude, right? Mm-hmm. Isn't trying to overcharge you, isn't becoming confrontational. But in medical school and training, which runs, 8-10 years, the only behaviors you're taught are from your mentors. And guess where they learned it? From their mentors. Mm-hmm. And guess where they learned it? So doctors grow up protected from the world. And that's a mistake because physicians have developed certain maladaptive behaviors. And I can speak to that because guess what? I'm a physician. So I went through all of this in my early years, so I can speak from experience. One of the most serious problems that doctors have is defensiveness.
Mm-hmm. What about, go ahead. I'm so sorry. What about people that are in med school right now? Are they training them differently?
I don't know. If I have enough time, I'm going to wander over to the medical school. I do know the CDC's in there with these slick ads and stuff teaching them not to use pain medicine. I don't know. Medical schools, there was a medical school when I was in medical school, it wasn't mine. They used to videotape the medical students and actors who would come in and be patients. And then they would review the videotapes. That's real important because then you can stop it, in the privacy of a little viewing room with the medical student and say, do you realize what an idiot you look like? Mm-hmm. Do you see how you're becoming defensive? Do you see how you're interrupting the patient because only you know how to get information? These are things that hopefully will be taught in medical school, but I think there's a way we can teach doctors by way of the patients. So I'm suggesting, and I need to go out back and live in a tent after I say this, but I think that we have to remember everybody gets up in the morning and puts their pants on one leg at a time. And doctors and patients are grown-up adults. And so when doctors start behaving like children, then the patient needs to behave like an adult and give adult responses. This is not something that patients are comfortable with because we've never done it. We've got this social thing that doctors have all the answers, and we're putting our lives in their hands, which is true. But it's time that that gets a little modified. We don't have to have that paternal, maternal structure where doctors know it all. When my plumber comes, and one did recently, we got into a little bit of an argument or discussion, and I listened to what he had to say, and he listened to what I had to say, and we finally decided to come up with a compromise.
He brought you donuts.
Yeah, so, he compromised, and I compromised, and he installed a new furnace, actually, and it's worked great. So this is the kind of dialogue that needs to take place with doctors, but they don't like it. You see, we are brought up to sit behind the desk, and we know it all. And so this needs to slowly change. And one of the ways that it can change are little private, confidential notes to the doctor in the mail. The mail is the best way because most doctors' offices still have an in basket, and in the in basket are lots of things, but all the mail is in there. So as old-fashioned as it sounds, mailing is still effective. And what you do is you write confidential on the envelope, and you put in the envelope things that you would like the physician to know, adult to adult. These are adult issues, not medical issues, adult to adult issues. Doctor, do you realize how I felt when you said to me, blank, blank, blank? You just fill in the blanks. And you just tell a little story. Physicians are not used to hearing this. And most physicians, when they hear a little soft critique, are shocked. And a lot of times it's good because they're shocked in a way like, oh my God, did I really say that? You see, we are so patterned because of our trade. See, this is when trades come in. We're so patterned because of our trade that we've learned all these things that we just do it automatically. For example, saying when a patient's family or something starts asking probing questions, you say, well, who's the doctor here, you or me? And physicians just don't realize they're saying these things. But if they got a letter the next day from a family member that said, doctor, we were kind of in a public setting, and I asked what I thought was a reasonable question from a family of a sick person, and you said to me, blank, blank, blank. And I just want you to know that I did not appreciate that. And that's it. You don't have to rant and rave. You're giving corrective feedback, which is what teachers do. So the patients can quietly become teachers and teach the physicians what is appropriate and what is inappropriate. Now, is it going to work for everybody? No. And if they get mad or something, get a mad on, time to find another doctor. And you can send them a little note about that too,
How can we build a rapport with our doctors?
That's tricky. I think the part of the problem is they're only given 8 minutes to the doctors in the sausage factories. I never joined a sausage factory, so I could spend as much time as I wanted with patients. And actually, I worked at a community psychiatric clinic for people with low income. And it was wonderful because I could spend 5 minutes with somebody and then spend 30 minutes with somebody. And I'd just peek out in the waiting room and, make sure it wasn't getting too backed up. But then the lay administrators, we use the word lay for people who are not doctors, decided that I really needed to see everybody every 15 minutes. And I only had 30 minutes for a new patient. And this is the way it was going to be. And so I said, see ya. I would not work under those conditions. But a lot of doctors are under this sausage factory mentality. So the first thing I think that's reasonable to do is say, doctor, I know there's a lot of pressures to see patients. How much time do we have?
Right.
And then you get an idea, right? If he says 7 minutes, then you say, well, you know what? Here's my problem, and then I'm going to email you the rest. What I'm currently doing with the patients that I'm seeing, although my practice is closed to new patients, but I have them participate with the process. So normally you sit down with a doctor and you tell them the story. So then the doctor sits there writing it all down or typing it into a computer. So because my patients are complex, I tell them, look, make a bullet point history and email it to me. Then I can read it ahead of time. So then when the patient comes in, I can just ask a few questions. By the way, that's the way federal courts work. Different than state courts. In state courts, you bring all the information in there and blah, blah. In a federal court, you submit all the information first. So when the judge comes in, he's already got all the information. Then you can spend the time in the courtroom discussing. So if people mail in advance, if they've got a complicated problem, mail advance, email is best in this case. You know, you email in your little story, doctor, I'm going to talk to you about this, and here's my bullet points of things that I'm concerned about. Then the physician can quickly look over the list and then spend the other 7 minutes with you trying to figure out the problem. So understanding what physicians are going through. Physicians are led around by a leash by people making tons of money. It's kind of like aphids. Do you know what little aphids are that get on rose bushes?
No.
Yeah.
Oh, you mean like the little thorns?
No, they're little tiny insects, and they suck juice out of the plant. And guess what? They're cows for ants. So the ants come by, pick up these little aphids, and take them back to their nests and milk them. Right? So, you know, I always call this the aphid syndrome. Doctors have become aphids. You know, the corner office people driving the big cars, you know, come down at the end of the day and collect up all the money from the doctors, you know, and it gets kind of bad because then they start doing things like, doctor, you aren't getting enough CAT scans, you know, but you're working for somebody else. So you can't do much. So if you understand, as a matter of fact, it's a good question to ask when you go into a practice. Are you working for yourself? Are you employed by yourself? Or are you employed by someone else?
Like in a bigger,
ask it in a nice way.
In a bigger setting, do you mean, or?
No, wherever you are. You know, a lot of doctors have sold their practices to hospitals because hospitals then they have a new name for your patients.
What's
covered lives.
Covered lives.
The hospitals refer to you as covered lives, which means you are now covered in their hospital system. So if Dr. Fernandez joins the hospital practice, all of the patients become feeders to the hospital, more aphids. And so they are called covered lives. This happened to me when I was at the Mass General in Boston. They were changing around, and they were going to beef it up, and they were going to form these partnerships and blah. And they came around and they said, and they just slipped out. You know, these people that were not physicians, it slipped out. We're trying to get more practices in the hospital corporation because we'll have more covered lives. And I raised my hand. What's a covered life? Exactly. And the guy looked at me like, oh, that means you know, that if it's in your practice and they get sick, they'll come to the Mass General. Oh, I see. Covered life. That's interesting. Yeah, he was about 26 and, you know, had on a $300 suit, $400 suit. Anyway, so understanding that the physicians no longer have control over their practices, most of them. If you go in there and say, who is the doctor work for himself? And they say, no, he belongs. So right away, you know, he's got a leash around his neck. And so you need to make it easier for the doctors to have time to think about the problem. And so you can do that with these little supplementary before the visit, send in your little email list, or if you have an article, you send it in the mail. See, then it gets into the mail in basket.
Okay.
And you have an article that you found, you know, on your disease. Maybe you have a rare disease and you just put FYI. Or you can put just little short notes, nothing like you're arguing, you know, just, do you think this might be me? Here's a palliative care article a friend of mine gave me. Never say it's coming from a doctor. This article a friend of mine gave me that we're circulating. It's just for your information. And so you drop in the article about palliative care. And you see, the reason I did this is because the second half of the article teaches doctors how to make a lot of money, actually quite a bit of money, on chronic patients with painful disease.
Like on treatments?
Because they can be paid for time when they're not with the patient. This is the first time ever that the rules about payment have changed. So if you have a patient with a long-term disease, you can bill for time that you're spending when the patient's not there.
Yeah, I used to, I noticed on my health insurance claims, when I went through all the different things that she was charging for, because there was a list, and it said in there a few times, talk to patient about quitting smoking or however that is. And she never did that. So
okay, yeah, she was probably being paid under the chronic care management, CCM, chronic care management codes, which are unlimited. I mean, they always limit us. Not as doctors, they're just going to run up the bill. But if you can document what you've done, if you spend 6 hours a month on one patient, you can be paid for the whole 6 hours.
is it legal? I know there's like two-way states and one-way states. Is it legal to record your doctor appointment?
That does vary. And if you ask a doctor if you can record the appointment, they're going to get really defensive.
Right.
I think it's a bad idea. You can take notes. A lot of people do that, a little steno pad, just jot down notes as the physician is talking. And that's usually, the docs feel that's okay. That just seems that you're being responsible. And they did a study once. After leaving the doctor's office, within 2 hours, they sat down with people and they said, what did your doctor tell you to do? Do you know that 50% of the time they got it wrong?
Really?
So some docs write things down. I used to have a pad with a carbon underneath, and I would just jot things down as we were talking. And then I would hand it to the patient, and they'd go, how do you expect me to read this?
Yeah.
But
now
then I worked
tablets.
on my penmanship. But patients can do that too. Take a little steno pad and just nod and write things down and say, Doc, I got a terrible memory. I just want to write down everything here. And that's okay to do, but not recording. I wouldn't do that.
So we need to find a common ground between patients and doctors. So how do we actually talk to our doctor? Is there a certain language or jargon patients can learn when speaking to their doctor to benefit them?
If you start using doctor language, I think you'll get one or two responses. You'll get, okay, this person is informed. Or then they'll get mad, because they're being challenged and become defensive. But I don't think there's anything wrong with using a few words like indicated. When I say that a medicine is indicated, that's my doctor talk for this is the medicine we should use. If a person has a pain from their painful disease, then I say, I think opiate pain medicine is indicated. And patients can use that too. It's kind of breaking the wall, the fourth wall between the doctor and the patient, I think, to use some of these terms. It's not going to always work. Some doctors are going to get defensive. We use the word contraindicated, which is a very strong word that means we would not use this under any circumstances. An example would be a person with a penicillin allergy where they collapsed. Now penicillin is contraindicated. What is indicated for that patient might be erythromycin. So we use the word indicated and contraindicated. Now it's interesting that in the 55 pages of the voluntary, non-mandated CDC guidelines, they do not discuss indications. In other words, uses. There's nothing in the guidelines about when you actually do use opiate or narcotic pain medicine. Narcotic is my preferred word because it covers fentanyl and covers all the drugs, narcotics. There's nothing in there. It's just a diatribe on not using pain medicine. When you sit back and look at it, it's really bizarre. I mean, normally if the FDA puts out the word, let's say, on a new narcotic drug, there's a whole bunch of things about when you use it, and contraindications when you don't use it, and side effects and adverse effects and blah, blah, blah. The CDC does not discuss indications. When should you use pain medicines? So that is weird. And I don't think they realized it because they were on a different horse. They were looking to put forth their personal views of a few people at the CDC and their consultants, their personal views that narcotics are bad for you. Now, this is something that's been around for 100 years. We've had zealots before. I have some nice quotes. I'll have to bring them in next time. Back in 1915, these are the worst drugs in the whole world. This is bringing down our civilization. Narcotics. So we need to try to talk to doctors about the CDC and the FDA. Now that's tricky. That may be something you'd want to do ahead of time through an email. Say, doctor, I was reading that the FDA is really the legal entity and that they do not have any limits on how much pain medicine you give. A lot of doctors don't know this because who's telling them? The only information they're getting about pain medicine is from the state, their little sessions, the CDC sessions. I think I told you I started a CDC module where I could get credits for my continuing medical education. I stopped halfway through and I don't want credits for this. These things are not true. They were saying things that were not true. So physicians have bought the CDC guidelines, and they need to understand that the FDA guidelines are the real legal ones, and they don't limit treatments.
What about the jargon or language that you're teaching all of us? Like, use pain medication instead of opiates or narcotics. There's a whole bunch that you say, which you should make a book about.
No, I would start using the new terms, because every time you use a term that's old, then you get all the baggage along with it. One of the difficulties with doctors, some of the things that are trigger points are, doctor, before I was on oxycodone 90 milligrams 4 times a day. The minute you say that, you're a doper, because dopers know what they were on. So again, this is something you cannot bring up during the visit. There's not enough time. You end up arguing and not. I just listened recently to somebody who did tape the interview with their doctor, which was an 8-minute. It was awful because she was trying to defend herself, and there wasn't enough time. So she was just blurting out these things. The doctor's over there going through well, I don't know. This is. So the physician ended up cutting her doses without telling her. So she goes to the pharmacy and picks it up as a half a dose. That's reportable to the Board of Registration in Medicine. That's crossing the line. But she could have maybe avoided that by advance information. Doctor, here's a list of medicines that I've been on. Here's the one that worked the best. And star the one that worked the best. Physicians, they're all now currently are into this. You got to try all these other things first, which I totally disagree with. But you can help with that by advanced list. Doctor, here's the things I've tried, and here's the things that I've not tried. Now, I find in my own practice that's real helpful, because I don't sit there wasting time going, have you ever tried brand X? Well, if it's on the list that you've tried brand X and it didn't work, then we can just skip that and move on to something that's more relevant in my 8 minutes. So,
should all patients have their entire medical records? Like, I asked my primary care doctor the last time I saw her if they have my records, and they don't. They only have like a few years back, and I've had issues for 24 years now. Is this what problems like Narcs Care in North Carolina would help with, or no?
No, they're not. The Narcs Care and the Prescription Drug Monitoring Program are police tools, law enforcement tools. They are not clinical tools.
Okay.
The doctors become kind of lurid, looking in there and see if they're going to catch their patient going to another doctor. Come on. That's not what we do. Let somebody else do that. If they're so concerned about people being doctor shoppers, the world's worst crime, 60% of which are pain patients not getting enough medicine, and they peer and, oh, we're going to catch these people. They're playing like junior FBI man. So no, it doesn't help me at all. I'm required to look into it. So I get somebody to help me with that, and they look into it, and I never even read them. I don't care. So what if they're going to 2 doctors? That's not my business. Oh, but doctor, you should know that, so you don't give them too much and they won't overdose. No, if they're lying to me, hey, what am I going to do? And every once in a while, people are going to lie to you. I mean, people lie to their plumbers, and people lie to their electricians and their hairdressers. You can't guarantee you're not going to have crime. And by the way, this APRIS PDMP last year in North Carolina, guess how many doctor shoppers they caught? Hang on to your hats.
How many?
5.
Really? Now, is that
so
in the state or the
they're spending $500,000 a year to catch 5 doctor shoppers.
Wow.
So what are they? Wait a minute. I thought this was a disease, everybody. Is it a disease? Oh, no, we're out arresting them. You see how talking out of 2 sides of their face. So we're spending all because of, why are we doing this? Fear of addiction, phobia. That's why we're doing it. 5 dopers were caught. That means 5 less people ranging the streets, raping and pillaging and burning houses down. See, the secret is narcotic. Narcose is sleep. So the average narcotic addict, type 2 addict, is asleep, right? Mm-hmm. Nodding off. We're not running around the streets. I asked one addict, I said, well, what about all these stories of sex crime? He said, are you kidding me? We don't have sex at all. We're under this narcotic all the time, and incidentally, when addicts go into rehab and stop taking their narcotics, they go crazy sexually. They just have a great time. They said that's one of the best things about being in rehab. Is everybody just kind of like cuts loose. So here we're creating these situations that nobody even knows about because we're not talking to people with addiction disease, which we're going to start doing soon. Mm-hmm. So we can all learn about addiction right from the people with the disease. So no, in medical records, I've always, I don't know why, I guess I work for some medical records people. Please send me the medical records. Well, there's 200 pages, right? So I got a couple of times, I got these 200 pages and I went through and I thought, I think I've used 1 page that I thought was relevant. All the rest are these required forms. You can't even read them. You can tell they were all just punched in there. Nobody was thinking about it. So I never get medical records right away because I trust the patients. Then if the patient says, well, I had a CAT scan 2 years ago, then I get the CAT scan report. So then I'm not wasting time in a medical records department. I just say, send me this. God, they used to love me at the hospital because I would just send down a request for 2 things, instead of 600 pages of nursing notes. It's just a waste of time. It's kind of one of those catchphrases, get medical records. Want me to bring my medical records? I saw a patient the other day. She had them spread out on the floor, and I said, and I kind of glanced at them and I said, well, just give me that lab test and this and give me 5 of those.
I remember toting around my MRIs and all of my records in that way. That was a lot. And they're big. Yeah.
In other words, always say, well, exactly what would you like to have?
Okay.
And then people can say, well, special studies, lab reports, MRI reports, X-ray reports, consultations with other people. Those are good to have. But you certainly don't need all the rest of that stuff.
Okay. Miss Harris from YouTube asks, I have no idea what the nod off is. Why do some people do that and most don't ever?
Nodding off is for addicts. It's when they have too much narcotics on board, and that's the prelude to overdosing. And guess what? When the alcoholics are unconscious, same thing.
Okay.
When you're that impaired, you're getting ready to overdose. This never happens in my 43 years patients taking prescription meds. This is only for people who are taking enormous doses of pain medicines. They're taking pain medicine.
Well, let me ask
Heroin
you,
is actually a pain medicine.
Yeah, all right. So myself, I mean, I've firsthand seen this, and I've talked to a lot of other people too, and patients, and they have said the same. When I've been at my doctor, usually my pain management doctors, I mean, I've literally seen people out there nodding off in their seats. Is that too much? And I felt like, some of those patients, they would continue to prescribe for them. And I mean, you would see them all the time. Whereas someone like myself, I've always taken my medications the way I was supposed to. I've never, called in early for a prescription. I've never lost my prescription, nothing like that. And they've given me a hard time. Why does that happen?
Fear of addiction, phobia. People are not using reason and critical thinking. Now, you got to be careful. Always look for the alternate hypothesis. In science, if you get an idea, you always look for a confounding variable, which means another hypothesis. So why would people with pain disease be nodding off in the waiting room?
Why?
What happens when you don't get enough pain medicine? What kind of sleep do you get? 0. So a lot of the people in the waiting room, that's a symptom that they're not being treated enough because they can't sleep at night, and now they have sleep deprivation. And one of the symptoms of sleep deprivation, in addition to screwing up your personality, causing depression, is that you will nod off suddenly. It's a danger. Like if you're driving your car and you have sleep deprivation and there's a traffic light, you can just nod off.
This is something I've always wondered. If somebody, either an addict or somebody's on too high of a pain medication, and they are nodding off, well, I'm so sorry. I'm going the wrong way here. I lost my thought. If I'm taking pain medication and I'm having an addiction, and then I start having withdrawal when I don't have any more, what's actually going on in my body, and why the moment that they're back on a narcotic or a pain medication, it goes away? How does the body change that quickly?
The details of that are unknown. When I was at Stanford for the Medicine X conference, the guy who invited me at Stanford was a full professor, and his expertise was withdrawal. Okay. They don't know exactly what causes withdrawal in type 3 alcoholism, in cigarettes, in opiates. It's kind of a funny mechanism. It's kind of like the receptor is looking for the stuff that goes in the receptor, which, by the way, is called a ligand, L-I-G-A-N-D. The ligand is the little needle you put in the basketball. Mm-hmm. So each ligand is different, and it fits in lock and key. But somehow when the ligands disappear, it changes the receptor physiology. It's called uploading and downloading. It has to do with closing down receptors and making more receptors. But that in itself doesn't explain why you feel so bad. People that have quit smoking, people have tried to stop alcohol in the type 3, people that try to stop opiates. It's just awful. However, it does appear most addicts can detoxify. That's a word only for addicts, by the way, and it's being used for other people. Detoxifying an addict, they can usually do it in about 5 days with decreasing doses. But it's a good question, and we don't have a clear-cut answer as to what the chemistry is that's going on.
I've heard also from a lot of people that were addicted to narcotics that they that they said that if they didn't have the withdrawal, they would quit immediately. Is there any way to stop a withdrawal, or why is it so hard?
It's just tough. It depends on the person, depends on the person's biochemistry, depends on the agent that's going on. And one thing I do not have an answer for yet is why there's withdrawals stopping antidepressants. And also, in my personal experience of taking people off antipsychotic drugs, about 30% of them had a withdrawal syndrome from regular old antipsychotic drugs,
Yeah.
So I'm not quite sure. It's fuzzy in my mind, but it is a marker that you have a deep chemical interdependence. We're going to stop using the word dependence. A interdependence between you and the agent.
Okay. CGF from YouTube asks, what is cardizem? Or cardizem?
Cardizem, how do you spell it?
Cardizem.
I don't know. I have to look it up.
Okay. Yeah, I don't know either. We have a caller from area code 980. What is your name and what's your question for Dr. Kline?
Hi, this is Jessica.
Hi, Jess.
And I have a question that actually had a lot of people ask, and I need to know myself. What are some infuriating things that you do not want to say in front of a new doctor? Like words that will instantly infuriate the doctor?
Yeah, good question. It kind of depends on why you're there. Acting like you know all the answers is irritating the doctors. So if you're going to present it, you present it in a diplomatic way. This is where diplomacy comes in. Doctor, this oxycodone really worked best for me. Now, a diplomatic way would be to say, Doctor, I've tried about 8 different things. Here's a couple I've tried. And the one that I seem to have had the best sleep with, and the one that I seem to have been able to function the best and get up off the sofa, is oxycodone. So you see, that's a way to not trying to one-up the doctor. So doctors do not like to be one-upped. So think of ways to say things that are diplomatic. I mean, diplomacy is a good general skill to have in life, whether you're talking to your plumber or your boyfriend or, a close relative. Diplomacy always works best. Instead of saying, to your sister-in-law, Joanne, you're really an ass. Diplomacy would be, if you were a diplomat, what would you say? And you kind of think in your mind, what would you say if I was, say, an ambassador and I was being irritated by the country I lived in? Would you just say, well, you're a bunch of jerks? No. You think of kind of a way to put it that's diplomatic. It's a skill that you can develop if you practice it. And you can use it on your children. You can use it, in life. How to say things to somebody else in a courteous but firm manner. Okay. Still have to be firm. Yeah.
By the way, Jess put up the definition of cardizem on YouTube, and it is calcium channel blocker with antihypertensive drug, and it can treat high blood pressure and chest pain.
Okay.
So, thank you, Jess, for pointing that out. So what should patients share everything with their doctor, especially if it's a newer doctor? Like, should they share the entire truth of their entire past about, maybe trying, different drugs in college just because they're young and stupid, basically? Because many CPP patients are afraid to share everything because of previous issues they've had. So how should a patient handle this?
Well, it's kind of like, my plumber comes by, I hire him, I pay him money, he's a professional, and he comes to look at my house. And I start telling him about all these problems I had as a boy. And, no, he doesn't want to hear that. He needs to hear information about my new furnace. So your doctor only needs to hear information about your current problem. I think giving too much information increases the bias. See, there's the CDC got another falsehood going that people with addiction, again, not define addiction, well, which type of addiction, have all these problems in their childhood and were abused, and none of that is true. But by just bringing it up, you see, it starts a bias. So if you bring up with your doctor, oh, I was abused as a child, beat up, then they go, yeah, no wonder you're a doper. No wonder you want these pain medicines. So no, I think you need to give specific information to the physician about your current problem. Now, if you're in a psychologist's office and or psychiatrist and you want to talk about being abused, it's a different story, But if you're in your regular pain management doc, no, absolutely not. Don't give more information than you need to. This is not the confessional.
Well, a lot of PPs also have told me, and I've even experienced it, that if they know too much as well, then they have an issue. Like they're too intelligent or too much information on that. Doctors take that as a possibility that they're drug seeking or.
Yes, you gotta until doctors learn a new way of sharing with the patients. This is called, I just thought of this, it's called patient-centered medicine. What a joke. They actually have, you go to courses, patients, gee whiz, this is just like every other tradesman, plumber, electrician, hairdresser. Yeah, you interact with one another as adults and you participate in your decision. You don't go to a hairdresser and they say, we're going to cut it real short this time. Yeah. It's a participatory thing. So, it's the same thing with doctors, and they need to learn that. And you see, one of the ways I think we can teach doctors that is with this preliminary information prior to the visit. And then they can kind of look at it and go, oh, okay, you want long hair, okay, I don't need to get into an argument with you about how I think you look better with short hair, and you can avoid that. So it's a slow process. But yeah, if you start bringing up too much stuff, then the physician gets argumentative. And the reason now that it's even worse, the physician knows they've only got 7 minutes before they have to start typing into their EMR. So they know they don't have time to argue with you. So they don't.
Well, and do physicians also know that it's kind of stacked against, especially with pain management doctors, like patients don't have a lot of options or alternatives if they don't go along with their doctor. What do you think about that?
Yeah, I think that's a big problem. But I also think a lot of pain management has just all of a sudden appeared in the last 2 years, become a cottage industry.
What does that mean?
Well, a cottage industry is like something that pops up out of the necessity of what's going on in the world. So in other words, you have kind of a new business starting up. Cottage industry means it's small. Like if it's real cold out, then the cottage industry would be to make shawls for people out of wool. So if there's a lot of problems with pain being or doctors refusing to treat pain, then all of a sudden all these cottage industries pop up with pain clinics. Do pain clinics, are they registered? Are they licensed? Do they have rules? Do doctors have to have certain qualifications? Is there a credentialing process? No.
Well, and oftentimes too, they have all these different treatments or want you to have these like unnecessary surgeries, like a SCS system, or or the shots, or for me, they wanted to put a chest port in me.
Yeah, it's anytime something sounds funny to you, speak up. My rule of thumb with pain clinics is, okay, yeah, I'll be happy to consider that. See, that's diplomatic. Consider doesn't mean you're saying yes or no. I'll be happy to consider that. But first, I think we need to do the FDA titration on these oral pain medicines and make sure they don't work. Yeah. And if they don't work, then I will consider the spinal stimulator or the garlic bag around the neck or going to mindfulness sessions or Tai Chi or whatever other cottage industry has popped up. The cottage industries have gotten so bad that in Oregon, they're trying to stop all pain medicines in people on Medicaid. That's nice. All the people that are poor and disabled, screw them. And all the people on the board were cottage industry people. There were acupuncturists. There were psychologists who do mindfulness. Everybody that can make money, you see, this is called profiteering. You make money on the fact that doctors are all suffering from fear of addiction, phobia, and so they're just sending their patients to anybody as an excuse. And all these little cottage industries go, yeah, whoa, we need to stop all this pain medicine. Look at the business it'll generate. Because then people are in so much pain, they'll do anything. Stick this thing in my body for $50,000. It only has a 20% chance of working. I don't care. I'm in so much pain, I'm going to kill myself. So this is a very serious healthcare profiteering.
Well, and if doctors are doctors, they've gone to med school, they've been around, a lot of them, if they're older, they should know what pain looks like, or they should be listening to their patients. I mean, how does a patient, get this through to them without coming off as that, they're being fake or not?
You can't, not during the 8-minute interview. You got to do this ahead of time.
Yeah.
You got to do your little bullet point. Don't go on and on with these long paragraphs with no breaks. Nobody's going to read it. You got to do a little bullet point. I was on blank medicine. I was going to church. I was having sex. I was going down to the store. My medicine was cut. Now I'm not having sex. I'm not going down to the store. I'm spending my time on the couch and I can't sleep and I'm having sleep deprivation. In other words, just facts. It's like you're writing a newspaper article. I just wanted to fill you in, doctor, ahead of time because I know you're real busy.
Do you think patients are honest with you?
With me personally, or with doctors in general?
Well, with you, and then also, but as an in general question.
No, I don't think they're all fully, because people have the right to dispense information the way they wish to dispense it.
What have you noticed that they usually tend to stay away from or withhold?
Nothing in particular. You mean me withhold stuff?
Well, no. I'm just wondering from a doctor's point of view, like what have you seen, and how do doctors kind of? I'm trying to understand how doctors kind of look at us, and
yeah, no. Good doctors just want the information so that they can put in the furnace. They just want the information so they can figure out what your disease is and how to treat it. Doctors are not so much interested in what kind of a life you have or your background. Some are, some like I kind of like to know what people's backgrounds are and where they grew up. But not all doctors. Doctors are technicians, they're tradesmen, and they need to do their trade, which is making a diagnosis and treating the disease. So the more you're focused on that, the better. It just depends on the physician. Some physicians are real friendly and some aren't, and both are okay. You get too friendly, you spend too much time gabbing and not spending time on figuring out what the diagnosis is or thinking about the treatment, So
we have a question from YouTube. There's a new blood test prick that measures your pain with different colors. Do you know what that is?
No, but I'd like to know more.
Okay.
Because we are desperately looking for tests to show the level of pain. There's been some progress in what are called PET scans, PET scans, which are real fancy MRI type scans that are showing up inflammation, like in people with chronic fatigue syndrome and what I call systemic inflammatory diseases. These are systemic inflammatory diseases. Your whole body's inflamed and your brain's inflamed with the brain fog and something's going on, and there's no blood test that I know of for that, but PET scans are very expensive. The best thing is for doctors to do what they've always done, which is to sit there, listen to their patients, and then move to a diagnosis. Not sit there and listen to their patients and then judge whether or not they're fibbing to you. So what if they're fibbing? You can't have an adversarial relationship with your customer. If the guy comes to look at my new furnace and he thinks right away I'm going to cheat him, then we have an adversarial relationship. It's not going to work. You have to trust people. That's the basis of our practice. You have to trust what people are saying. And if 1 in 50 people want to lie to me, then that's fine. Because I'm not going to grill the other 49 and be suspicious that they're trying to be hustlers.
How important is it that a patient brings along somebody else to?
I think it's a great idea.
You do,
and the thing of it, since 50% of people can't remember what the doctor said, having a second person helps. And I love it when a second person comes, because I think that's showing support. And also, I'm thinking, I'm rattling off all this stuff about what I think the disease is, and people with disease tend to shut it out. They don't want to hear it. But the other person that's with them does listen. And then they go home and they say, Barbara, he said that everything's going to be all right. Oh, I was worried, that I have cancer. And a lot of times they won't hear what the physician says. I think it's almost mandatory. And by the way, I think it's mandatory to have another person when you're in the hospital.
Yes, I agree. Few people have been talking about this. Somebody on YouTube says, I just took a genetics testing. In the future, can this potentially hurt me? And why?
Any kind of a lab study that has the potential to be falsely negative or falsely positive can be potentially harmful. So I would be real careful about what you're getting. I've heard a lot of these genetic tests are really pretty bad. You need to look them up. Say, well, doctor, what kind of test are you talking about? And go to the internet, and find out. Because yes, the one thing you don't want is some diagnosis you don't have, or missing a diagnosis that you do have. So you got to be careful about these genetic tests. I've got a lot of negative articles so far. Now this may get better as time goes on, but apparently it's part of the cottage industry, hustlers, taking advantage of people that are sick and say, here, let's get these genetic profiles and find out if you're going to get Alzheimer's.
Mm-hmm. Well, we're already after 9. This went by really quickly. Dr. Kline, what is the most important thing a patient can take away from tonight and about how to talk to their doctor?
Understand that physicians are under the gun time-wise, and to try to add additional information ahead of time before the visit. Don't hand a lot of papers to a doctor during a 7-minute visit. That's very frustrating. And understand that deep down inside, physicians really do want to help you. It's kind of like legislators. Everybody doesn't like legislators, but deep down inside, the legislators really do want to help. So remember that. It's not all negative. Doctors are under pressure. They've lost their ability to be independent. They don't just lean back in their chair and, spend 20 minutes with you. And the other thing you can do, by the way, if you have a complicated problem, is say to the doctor, well, we just gotten started today. Would it be possible for me to book a longer appointment next time? And most offices have that ability. They'll do a double, it's called. They'll give you 2 slots, and then they can charge for it. And you can charge more for more time. So understanding that physicians are really aphids now. They're really making money for other people. Their independence has basically been lost. 75% of doctors work for somebody else now. So only 25% of doctors are still independent. But that's just the way it is. So rather than complaining, understand what's going on with the physician. Understand you're not going to have time to argue during the visit, that you're like in federal court. You're just going to discuss things. Everything else has been sent in ahead of time. My patients email me with, all the time with, here's a little report on how I'm doing. And I just quick read it and stick it in the chart. And the next time I see them, I have all the information. They don't have to sit there and tell me that, they had this difficult time 2 weeks ago and they did this with their medicines. So, and I think most doctors are understandable like that. So set up a communication system with your physicians.
Okay. Well, thank you, Dr. Kline, for educating us on how to talk with our doctors and answering questions from the audience. And and a big thank you.
There appear to be a bunch of doctors outside with torches and pitchforks. You think I should worry?
Just put your head in the sand.
Okay, I better go now.
All right, be careful. And a big thank you to our audience for taking some time out of your evening to join us here at Nation. Again, I'm Janelle Elgaway and with Dr. Kline, signing off until next Tuesday. Have a good night. Thank you.
This has been The Doctor's Corner with Dr. Kline and Janelle Elgaway. Copyright 2018. All rights reserved.